Ouch! What to do in this situation?
We should apply price. So firstly, pain. Next, rest. Then ice, compression, and the last one, elevation. Although this patient presented primarily with an upper limb injury, we will still need to do the gait assessment for the musculoskeletal examination. Observing a patient's gait will help to identify the abnormalities of the patient's bones, joints, and muscles for lower limb examination.
For teaching purpose, we will now demonstrate several common abnormal gait patterns.
Firstly, don't forget to sanitize your hands before any physical examinations. Introduce yourself to the patient and explain what examination you will perform. Ask for permission and start to examine the hand, assess the finger and nail. Try to look at any abnormalities and you can move to the palm and observe closely. This is the Shamroth window test to check clubbing. It can be linked to long-term low oxygen levels or chronic lung diseases, heart problems or gut issues. Next, we proceed with the wrist to measure pulse rate. We proceed to the face. If the patient is wearing spectacles, make sure it is removed. And examine the central eye, check the color of the sclera and also check for jaundice. And then proceed with the mouth examination to see the patient's oral hygiene. Last but not least, we have to check the leg and feet to look for peripheral edema. We will do the upper limb examination. We will start the inspection at the shoulder part. First, inspect the shoulder from the anterior, lateral and posterior. Next, we perform the scapular winging test. Ask the patient to push against the wall or raise both hands.
Before we start palpate, always check for temperature difference around the joint. Then palpate clavicle, acromion and other joints around the shoulder. Next, we assess movement. Begin with active movement. Demonstrate first, then ask patient to copy. We test for flexion, extension, adduction, abduction, internal rotation, and external rotation.
We will proceed with hands and wrist examination. Inspect the hand and look for any abnormalities for hand movement. Ask the patient to flex and extend the fingers. Next, compare the temperature of both hands. Before we palpate the metacarpal joints, make sure the patient remove any rings they are wearing. So we will continue with palpate systematically the metacarpophalangeal, proximal interphalangeal, distal interphalangeal and carpometacarpal joints. We are doing the reverse phalanx test. Hold the wrist in extension for 1 minute. Both will produce symptoms in carpal tunnel. Next, this is the thumb adduction against resistance.
Elbow inspection. For palpation, feel the olecranon, medial epicondyle, and lateral epicondyle. Then compare both sides. For movement, test pronation of forearm and supination of forearm. For special test, lateral epicondylitis or tennis elbow, ask patient to extend their wrist against resistance. For medial epicondylitis or golfer's elbow, Ask patient to flex their wrist against resistance.
Anterior inspection. From the anterior aspect, look for scars which may suggest previous surgery or trauma. Assess the posture, noting any asymmetry that could indicate joint pathology or scoliosis. Check for asymmetry of the shoulder girdle, which may be caused by scoliosis or arthritis. Lateral inspection. From the lateral, evaluate the normal spine curves. Cervical lordosis may be seen in chronic degenerative joint disease, such as osteoarthritis. Excess thoracic kyphosis, which is normally between 20 and 45 degrees. Hyperkyphosis may indicate conditions such as Scheuermann's disease, where vertebrae are congenitally wedged. Check the lumbar region for loss of the normal lordosis, which may be associated with sacroiliac joint disease, such as ankylosing spondylitis. Posterior inspection. From the posterior, inspect overall spinal alignment for any lateral curvature that suggests scoliosis. Look at the iliac crest to see if there are level misalignments that may point to a leg length discrepancy or hip abductor weakness. Assess for muscle wasting, particularly of the paraspinal muscle or in chronic spinal disease, and reduce mobility. Note any abnormal hair growth indicate underlying bony abnormalities such as spina bifida, and look for bruising which suggests recent trauma.
For flexion of cervical spine, ask patient to touch their chin to their chest. For extension of cervical spine, ask patient to look up to ceiling. For lateral flexion of cervical spine, ask patient to touch their ear to shoulder on each side. For rotation of cervical spine, ask patient to turn their head to left and right.
Lumbar spine flexion. Ask the patient to touch their toes while keeping their legs straight. Extension of the lumbar spine. Assist the patient to lean back as far as they are comfortable. Flexion of the lumbar spine. Assist the patient to slide their left hand down the outer aspect of their left leg as far as they are able to while keeping their legs straight. Then ask them to slide their right hand.
Thoracic spine rotation. Ask patient to sit on the side of the bed and cross their arm across their chest and ask them to turn to right and left. For special test, identify the location of pieces on each side, then mark the skin in the midline 5 cm below and 10 cm above pieces, then measure the distance between two lines.
Okey tak ni?
Tak okey.
Cuba brace walk pula.
Cuba beri suap.
For gait examination, we will ask the patient to walk to the end of the room and then turn and walk back while we observe their gait. Pay attention to their gait cycle, range of movement, limping, leg length, turning, and footwear to find any abnormalities during their walking. High stepping gait. Foot drop due to weakness of ankle dorsiflexor. When foot contact the ground, forefoot strike first and the patient will raise their leg higher than normal people. Antalgic gait. Pain in the hip, knee or ankle. The patient will walk shortened stance on the affected side of the pain location. Trendelenburg gait. Weakness of hip adductor muscle, usually gluteus medius and minimus. During single leg stance, the hip adductor muscle prevent the pelvis from dropping.
Next, the quadriceps avoidance gait. Weakness or paralysis of the quadriceps muscle. Patient avoid knee flexion so knee remain extended during stance. Short limb gait. Difference in length between two lower limb. Compensatory movement to maintain foot contact and balance. Last but not least, the normal gait cycle. There are 5 phases of gait cycle, which is heel strike, foot flat, mid stance, and heel off, and toe off.
Wow, doktor.
How's your feeling? Are you panicked?
It's okay. I think I don't.
Comment several comments.